the best for last. The panel session is focused on staying connected and ensuring access for patients post-COVID-19, both federal and California laws and policy. This is exciting stuff, folks. So today's session is purely for informational purposes. The CTRC has no relevant financial interest, arrangement, or affiliation with any organizations related to commercial products or services discussed during the summit. Before we begin, I wanted to review a few tips for the event platform we're using today. Wahova makes it easy to access event features using a web portal or a mobile app. You can explore the agenda to view upcoming sessions, use the community tab to view topics, and start or engage in conversations with your other attendees. I've tried it out myself. It's great. Also, be sure to check out our sponsors who supported this event and view their offerings. Make sure your profile is up to date. Other attendees will use this to network with you. I'm looking forward to connecting with many of you. Today's session is being recorded and will be available to view through the event platform by next week. Lastly, please feel free to post your questions in the Wahova chat window. We'll hold the last 10 minutes of this session for Q&A. So with that, if we could move to our third slide. I'm Sylvia Trujillo. I'm the Senior Director of Policy and Advocacy here over at Ocean, where my portfolio includes a broad range of telehealth and other digital health policy issues. Prior to Ocean, I was at the American Medical Association for 13 years as their Senior Washington Counsel handling DC advocacy, where I again worked on telehealth, healthcare AI policies, and other highly disruptive areas of medicine like genomics. Really excited by the star power of our panel. We'll move to the next slide. First up is Monica. She is a partner and healthcare and life science lawyer with Foley and Lardner. She co-chairs the firm's life science and industry team and also serves as the vice chair for the healthcare industry team. She advises hospitals, health systems, physician groups on regulatory and compliance issues presented by telemedicine and telehealth. She covers topics like structuring and negotiating professional service agreements for telemedicine services and composing telemedicine policies and procedures. Next up is Jeremy, who is a health law partner and digital health co-chair at Hooper, Lundy & Bookman. Jeremy helps healthcare providers and healthcare technology companies navigate the digital regulatory landscape, and what a landscape it is, Jeremy. He advises providers, investors, and technology companies from startups through publicly traded platforms on issues involving healthcare technology, regulatory compliance, and business transactions. And finally, we have Katie, the Executive Director of Insure the Uninsured project based here in California. Katie has been central to advocacy efforts to maintain access to the most underserved in California. In addition to a stint at HealthNet prior to her current job and the nonprofit California Coverage and Health Initiatives, she spent a decade in California state government, including as a deputy secretary for the California Health and Human Services Agency and a principal consultant in the Senate Appropriations Committee in the legislature. So late last year, Katie and I both had the opportunity to serve together on the California Department of Health and Healthcare Services Telehealth Advisory Group. And we have a lot to share about what happened as a result of that work. It's pretty exciting. So if we could move to our next slide, I want to just set the stage so we avoid confusion. We're going to be covering a tremendous number of topics because during the COVID-19 public health emergency, both the federal government and California policymakers and elected officials implemented a staggering range of both regulatory and payment flexibilities to facilitate telehealth to maintain access to care. You all know that. Many of you know that. So as we figure out what's going to happen as the Pqhc starts to sunset, we want to break down both what the federal government is doing and what California is doing. And because of the complexity of the moving parts, we're really going to bifurcate this conversation into two. So we'll start with a discussion at the federal level of what PHE flexibilities we expect the Biden administration to retain, focusing primarily on Medicare and other federal regulatory flexibilities administered by the DEA, OCR, and OIG, the alphabet soup. And we will also see what our panelists think Congress will do to address the lack of authority that the administration may have to extend some of these flexibilities. And then the second half, we are going to have a conversation about what is happening here in California, primarily with the Medi-Cal program that the Newsom Administration and the state legislature. So with that, if we could move to our next slide, and we're going to talk about Medicare. But before we do that, I'm going to ask all three of you to kick this off with a really exciting question that I get really frequently. So I'm going to start with Jeremy and then go to Katie and then Monica. And if you could give your views on whether or not you think the public health emergency for COVID-19 is going to be renewed again. It's set to expire mid-October. What do you think is going to happen?
Well, first, thanks so much for having me, Sylvia, and everyone, and thank you for starting it with this. This is an area that is so often difficult to really provide tangible information because of the landscape, as you said, is sort of constantly evolving. And this one I actually think is fairly concrete. I think the answer is yes. The public health emergency will be extended again. Presumably, at least initially, for another 90 days. I believe it's October 13th is the date when the current public health emergency runs out. That's probably more for political reasons than anything else. I think the question is then, once we get into 2023, how far into 2023 or potentially 2024 will the public health emergency go? But fortunately, this was framed in a simple enough manner where I can just say, yes, it will be extended beyond October.
How about you, Katie?
Yeah, I agree 100% with Jeremy on not only will it, yes, be extended into the new year, but I also expect that it is for political expediency as well. You know, that to be cynical, but also we still are in the middle of COVID or in the middle of a wave. So, but I agree with him. I think we'll expect to see this go through the election and through the holidays. You know, but after that, I would expect it to be lifted, which I think is really critical. So a lot of the touch points here that we're going to talk about, the lifting of the flexibilities, the you know, in my world, Medi-Cal redetermination, all of that's really going to hit, I think, in the first calendar quarter of 2023.
And how about you, Monica?
Perfect. So I would love to play devil's advocate, but I think great minds think alike, because I agree with Katie and with Jeremy. It's with the caveat that I do agree that it'll probably be lifted in the new year in 2023. The question is when. I also think that it may potentially depend, you know, as this, you know, virus continues to evolve, if there are additional variants that come out that have unexpected consequences. Obviously, you know, the vaccines and the research have been very helpful. That would be the only caveat I would say as to maybe why it would not get lifted, if there was something unexpected in terms of a variant. But other than that, I agree completely with my fellow panelists.
So that is tremendously helpful to level set for everyone here. So in terms of thinking about your Medicare patient population, you know, we want to ensure that nobody becomes alarmed or concerned that what we're talking about necessarily is imminent. There's opportunity to plan, there's opportunity to make contingencies, and also to continue with checking in with CTRC, because we'll be able to provide updated information as the situation evolves. So with that, I'm going to really focus primarily these questions between the federal level with Jeremy and Monica, and then Katie will help us out with what's happening in California. And so Monica and Jeremy, as I ask these questions, you all jump into the question that you have decided you're going to take point on answering. So with that, I think we'd like to level set around, as a result of the PHE, what flexibilities were put in place to allow for telehealth in the Medicare program? If you could detail sort of the list of them, because everybody talks about telehealth, but there's a lot of flexibilities in there.
Jeremy, do you want to start with just kind of a broad overview, and I can go into some of the specifics?
Yeah, sure. And having the visual is helpful. So yeah, I'll sort of speak about it generally, and then maybe handle the first couple of items that are called out there, and then turn it over to you, Monica. Is that all right?
Yeah.
So overall, when we're talking about the Medicare program and telehealth, the coverage and reimbursement restrictions that are most onerous live in the Social Security Act. They are statutory. That means that an act of Congress is required to change them. And that's been part of the frustration that we've telehealth advocates like folks here have had for so long. During the COVID-19 public health emergency, Congress created flexibilities to drastically expand access to and coverage of telehealth services by basically either waiving or rolling back each of those statutory restrictions in one way or another. Those waivers are limited in their duration, and we'll talk about that later, sort of how long we think that they're likely to last. But again, as Sylvia said, sort of just to level set and to use the visual here, in terms of payment, in my mind, the biggest change during the pandemic has been the drastic growth of the types of clinical services that have been considered Medicare telehealth services. What that basically means is through the physician fee schedule process, CMS each year adds a few services that can be provided to Medicare beneficiaries via telehealth. There's literally an Excel spreadsheet that is updated annually, and it lives on the CMS website. You can look at it and look at all of the CPT and Hipaa codes for covered services. Historically, that list, it could be worse, but it could also be a lot better. It could be a lot larger. And normally through the physician fee schedule process, there are a few new services that are added each year. During the pandemic, I think last I looked, it was more than 200% the size of the list pre-pandemic. And that meant that all sorts of clinical services that folks maybe historically haven't been able to receive via telehealth have been available during the public health emergency. So the Medicare telehealth services list and the implications for payment is one item that is really important. Site of service, patient, talking about the originating site restriction, the real miracle, or among the miracles of telehealth, is the ability to meet the patient where they're located. But it has always been the case under the Medicare program that the patient's home is, with very few narrow exceptions, not an approved originating site, meaning that the patient can't be located at home when getting treatment via telehealth from their doctor, obviously, or from another qualifying practitioner, I should say. Obviously, the nature of the pandemic, particularly early on, made it so that we wanted folks to isolate, to stay in home, to not be out traveling and rubbing shoulders and all the rest of it. So that restriction was lifted for the duration of the pandemic, which has really allowed, it sort of created a laboratory for exploration and allowed us to get some data and to understand much more fully how Medicare beneficiaries react to telehealth, how they receive telehealth, whether what works and what doesn't. And then similarly on the distant site side, and we'll get into this a bit when we're talking about the Fqhc and RHC implications, but there were also changes made on the distant site side of things, which refers to the location where the practitioner is located when they are providing services from a distance. So those are the first three. Monica, do you want to take it from there?
Sure. Yeah, no, I'd be happy to. Thank you. And just, kind of drilling down, a little bit into this. I know there were some, specifics in addition to the slide that were asked about, what were the differences? Because as Jeremy mentioned, pre-COVID, the requirements to receive reimbursement from Medicare for services provided, via telehealth were very strict. And it really is through those reimbursement regulations that Medicare was able to, in essence, regulate telemedicine. And so the flexibilities, were and still are very helpful. And including, in addition to what Jeremy mentioned, there were requirements as to what type of modality, did you have to use in order to receive reimbursement from Medicare. So, essentially one of the waivers was that, CMS waived the requirement of audiovisual functionality. So normally, pre-COVID, in order to receive reimbursement for any services, the interaction between the patient and the provider, it had to be an interactive audiovisual function. And so they could not use telephones for services. Under the pandemic, CMS waived that to allow for audio only when you have, evaluation and management services, and there were new codes that they established not only for established patients, but also for new patients that were coming in and seeing the physician. Speaking of the practitioners, as Jeremy mentioned, there were certain types of practitioners that were eligible for reimbursement, and it included what people typically think of in terms of physicians, nurse practitioners, physician assistants. Under the waivers, CMS expanded the practitioners that could provide telemedicine services and receive reimbursement. For example, they included physical therapists and occupational therapists. In relation to licensure of these practitioners, in order to Medicare waive the requirement that the physicians and the nurse practitioners, et cetera, be licensed in the state in which they provide services. So, and I'm talking about requirements for reimbursement. Obviously, as we know, states have different licensure requirements, and we can talk more about that in the California portion. But in terms of, in order to receive reimbursement from Medicare, pre-COVID, the provider had to be licensed in the state in which the services were provided. Now, during the pandemic, that is gone, provided that the practitioner actually meets certain requirements. So in order for a practitioner to receive reimbursement and not necessarily be licensed in the state in which the patient is, that person, the provider, needs to be enrolled currently in Medicare. They actually need to have a license in the state in which it relates to their Medicare enrollment. So if I'm a physician, licensed in Illinois, and I'm enrolled in Medicare in Illinois, I can provide services to a patient in California and receive reimbursement, so long as I meet the licensure requirements. Again, separate from the California licensure requirements. Another requirement would be that the provider actually who provides the services in person or in telehealth is in a state in which there actually is the Phe. Here it was national, so that really wasn't an issue. And that the provider is not excluded from participation in the state in which they're providing the services or the patient is. You can't have been excluded. If the Phe was in California and you're excluded provider, you can't use that exception. Other CMS waivers that were pertinent included, the in-person requirements. So CMS actually relaxed enforcement of the requirement that the patient have a prior established relationship with the physician or provider prior to furnishing the telehealth services. So in other words, you are able to establish a new physician-patient relationship under using telemedicine technology without an in-person visit to receive reimbursement. And then there were payment changes as well, as Jeremy mentioned too. So for example, when you think about parity in terms of CMS reimbursement, now of course states have different commercial parity laws in terms of coverage parity of payment, but under Medicare, so prior to COVID, telehealth services were reimbursed at a lower rate than in-person services, but during the Phe, CMS relaxed that so that Phe reimbursement will actually be at the same rate as the equivalent in-person service for the practitioners, for people submitting claims for reimbursement. So those were all, and there were also, changes in terms of co-pays as well. Sorry, as I'm noticing that on the slide, I forgot that, where essentially the OIG announced flexibilities that would allow providers to reduce or waive cost sharing for telehealth visits that are paid for by Medicare. So that was another significant waiver that was in place, and it still is in place, still is in place during the PHE.
Great. Thank you both. That is a lot to take in, and there are many flexibilities. So really urge all of our participants to stop, think, and listen when folks are talking about flexibilities or terminating. It depends. As we're going to segue into the next part of our discussion, it's really important to understand that the federal government isn't going to necessarily decide that all of those flexibilities that Monica and Jeremy have laid out are going to be the same flexibilities that are either terminated or that are extended. So we'll ask them if they have a sense of which ones we get to keep and which ones are likely going to have to require an act of Congress to keep. But before we do that, I would really welcome, because we have so many community health clinic members and providers that participate in the CTRC activities. If I don't know, Jeremy, if you're going to run point on this, and maybe you do the first pass at it, and then Monica, anything you want to add, but can you speak a little bit to what this means for federally qualified health centers and rural health clinics that typically have different coverage requirements and payment amounts, and sort of what happened during the pandemic, what flexibilities came into play for them?
Yeah, sure. I'll start off and then invite Monica or Katie or Sylvia, yourself, anybody else to chime in. I mean, I think FQHCs and RHCs obviously have there's plenty about them that is different. They're also, at the end of the day, as I don't need to tell the folks who are attending this conference, they're healthcare facilities, and they treat a lot of Medicare and Medicaid patients. And so a lot of the flexibilities that we were actually talking about from my perspective, the left side of the slide really did help quite a bit for FQHCs and RHCs. Of course, the way that payment works for these facilities is a little bit different. So there were changes to the global payment structure, but fundamentally, the same sort of changes happened where rules were changed to make access to drastically more services available via telehealth in the FQHC and RHC context as well. There are two things that I want to focus on there that, as I sort of think about the experience of these facilities, I focus on. One is the idea of the FQHC or the RHC being a permitted distance site facility, and meaning that the services that are provided while a practitioner is located at the health center, but is treating a patient who is located at home, which, by the way, is okay because of the flexibilities that we talked about on the left side, that is something that can be done and that has been possible during the pandemic. It's made a really big difference. The other area that comes to mind is the coverage of audio-only services. When you're thinking about FQHCs and RHCs, you're thinking about a lot of folks who are in a position where having access to broadband such that you can have that synchronous audio video interaction, which is a fancy way of saying a video visit, that connectivity may or may not be there. And this was an area where I actually thought early on in the pandemic, we all complain a lot about the agency, about CMS with regard to telehealth. And I actually thought they did a really excellent job being completely transparent. And during these town halls they were having at the beginning of the pandemic, while we were all figuring out how to use Zoom and whether our Wi-Fi worked because we weren't going into the office, and you had hundreds of people calling in and listening in on these calls and talking about their frustrations, and the loudest folks in those discussions were often these provider facilities, and CMS on the audio only issue in particular. If you look back at the first interim final rule, expanding coverage and changing Medicare rules during the COVID-19 pandemic, which came out in the beginning of May the March 2020 rule first said that they would cover audio only services, which was great. And it was a great step. What was interesting was then in the second interim final rule, they came back and they basically said, we had no idea that people were going to rely on audio only care as much as they have as a way to access care. And as a result of that, in addition to covering audio only services, which is something that CMS historically has not done because of the definition of an electronic communication system in the telehealth provisions of the Social Security Act, they also decided that they were going to cover those audio only services at the same level as the corresponding audio video services, which made a big deal and was really a big difference in my experience when working with FQHCs and RHCs. All of this, of course, is somewhat up in the air, and we will talk about this, I think, in a few minutes, sort of how long we think those flexibilities are likely to remain. But in sort of looking backwards and thinking about the pandemic, I mean, those are the changes that come to mind, at least for me, on the FQHC RHC side.
Monica, anything to add?
Yeah, I mean, I agree with what Jeremy said. I think he did a good job of really, summarizing the things that seem to have the most impact on, the FQHCs and RHCs. I mean, I would agree with him. I mean, the patient's home being, an eligible originating site was very important. The fact that, he mentioned while, FQHCs, could have been, they were always permitted to be an originating site. Now they're actually permitted to be, a distant site. They can, bill for that, which is, incredibly important. I mean, any service that Medicare had approved to be furnished via telehealth, can be provided by an FQHC or an RHC during the pandemic. That was a big, that's a big important factor. It's mentioned, coverage for virtual communications, and it includes online digital evaluation and management services. For the purpose of Medicare, those services are not considered telemedicine or telehealth, if you will, and they're reimbursed at a different rate. And then, in terms of billing for digital EMM services during the pandemic, that is something that, FQHCs and RHCs can bill for. So I think that it's, I think that it's going to be important, not only, due to the increased billing capabilities and the payment, coverage for, FQHCs, but also other providers as well. Sylvia, to your point, as we look to the future and think about, when and if, the pandemic is going to end and what is going to be rolled back in terms of these waivers and the coverage. And I know we'll talk in a little bit about, the new, proposed rules for, payment schedule and what's going to be covered and all that. But I think it's critical for RHCs, FQHCs, all providers to start trying to plan now and use this time that we have to look at your current practices, look at your procedures, look at how you're billing for things, and try to the extent possible, make sure that when this goes away, because frankly, we all hope that this does go away, the pandemic, not necessarily the waivers, but that you are in a position that you're able to still operate and receive reimbursement from Medicare, Medicaid, and from all the payers.
Great. I think that's a really good segue to what we can do in terms of peeking into the future with regard to the physician fee schedule. So just so everybody's again level set annually, CMS issues Medicare payment rules, and one of them is called the physician fee schedule, and it includes payment policies covering not just the fee for service for physicians and accountable care organizations, but also payment policies for federally qualified health centers and rural health clinics. And so getting a great overview sort of broadly of what we've learned from the proposed rule for fiscal or cost year 2023. I'm going to turn back to Jeremy to what do we learn from what's in that proposed rule? And should any of those proposed changes be finalized, which would occur probably later this year, what would that mean for Medicare payment, in 2023.
And if you want, Jeremy, I'd be happy to jump in and talk about this. And then if you want to talk about the future, yeah. Sorry, Sylvia, when we were talking about questions, I'd be happy to kind of jump on this. So in July, so just last month, as Sylvia mentioned, CMS released the proposed 2023 physician fee schedule rule. So there's a few, key takeaways that we think are, important. And I'm going to go through 5 of them briefly that, if the rule is enacted, what would happen? So the first thing that I'll mention is that if this rule is enacted, essentially what they're going to do is they're going to create 3 new permanent telehealth codes that relate to prolonged evaluation and management services. And so the prolonged codes, the prolonged E&M codes would be, there'd be one applicable to hospital inpatients, one applicable to nursing facilities, and another one for home residents. So you're going to have 3 new permanent telehealth codes that can be used for reimbursement. Unfortunately, one of the not so favorable ones would be, and I think that these are important because it gives some insight into, what we'll talk about in terms of what we think may continue post Pqhc. So the second issue would be that they would actually discontinue reimbursement of audio only telephone evaluation and management services. So they would revert back to the modality requirement of it being interactive audiovisual as a requirement as the means for providing these telemedicine services. So that's the second thing the proposed rule does. The third one is it would discontinue the use of virtual direct supervision. Again, one that's not as favorable. So I think as probably everybody knows, under Medicare Part B, pre-COVID, certain types of services, for example, diagnostic tests, services, incident to physician services, they have to be furnished under the direct supervision of a physician or a practitioner. Now, for Medicare purposes, what does direct supervision mean? It means that the person needs to be actually physically present in the same office suite as the person they're supervising and immediately available to actually furnish assistance. Now, immediately available pre-COVID means in person, physical, not virtual, right? So they have to actually physically be in the same building as that person. In connection with the pandemic, we had a waiver that essentially changed that direct supervision, which would allow the supervising professional to be remote and to use real-time interactive audiovisual technology to provide that level of supervision. So that was a convenient waiver. So under the proposed rule, if the proposed rule is finalized, that direct supervision exception or waiver will expire at the end of the calendar year in which the Pqhc ends, right? So if it does expire in October, then the waiver would end in the end of December, so December 31st, 2022. Another thing that the proposed rule does is it actually postpones the effective date of the telemental health 6-month rule until 150 days after the Pqhc ends. So in 2020, Congress imposed new conditions on telemental health coverage under Medicare, and it created an in-person exam requirement alongside coverage of telemental health services when the patient's located at home. So under this rule, Medicare will cover a telehealth service delivered when the patient's at home if certain conditions are met. And so certain conditions include you have to have an in-person exam within 6 months of the initial telehealth visit. The service has to be provided for the purpose of diagnosis or evaluation or treatment of a mental health disorder. You have to conduct at least one in-person exam every 12 months. And so those are some of the conditions that 2020 rule imposes. Now, the rule, the proposed, the new proposed rule coming out that's enacted, it would actually postpone that effective date again until 151 days after the PHE ends. So the other two things I think are important to touch upon in terms of the new proposed rule is it extends, or again, if it's enacted, it will extend the coverage of temporary telehealth codes for another 151 days after the PHE ends. So the codes that Jeremy mentioned at the beginning that are temporary, you have a grace period for another 151 days. Again, something to consider in terms of planning when you're looking at, your billing practices, the services you're offering. But then the proposed rule also offers, it will add about 54 codes to the Category 3 telehealth list. So the Category 3 telehealth list contains services that, essentially are likely to have a clinical benefit when delivered via telehealth, but lack sufficient evidence to justify permanent coverage. So CMS proposed, again, 54 codes to be added to this Category 3 list, and those services fall into 9 categories. And the 9 categories are therapy, electronic analysis of implanted neurostimulator pulse generators, transmitters, adaptive behavior treatment, behavior health, ventilator management, speech therapy, ophthalmology services, if I'm recalling correctly, and then audiology services. So again, those 54 codes, if this is enacted, they will actually be added to the Category 3 telehealth list. So it seems that I think some of this gives us an insight, and I'll let Jeremy speak to this. Between the comments seem to suggest that, to me, the comments seem to suggest that CMS rulemakers do anticipate that this is going to come to an end at some point, and that the waivers will actually expire.
Yeah, that's a great jumping off point, Jeremy. I'm going to phrase my question to you just a little bit different. So we heard Monica mention the 151 days. And so I'm going to ask you to speak to what Congress has to do, given it's very clear from the proposed rule that CMS has tried to maximally exercise the authorities that they statutorily have available, but that is really quite limited once the PHE sunsets. But there's been some activity on the congressional front, and maybe you can touch on what the 151 days magic number is all about, and what relief, if any, we see coming from the federal, from Congress, rather.
Yeah, I can certainly do my best. Where the 151-day number came from, I still haven't gotten a satisfactory answer. If anybody has one, please let me know. What's interesting about, and I'll sort of start on the waivers and sort of Medicare's authority and the physician fee schedule, and transition into sort of more broadly the congressional activity you were mentioning, Sylvia. It's interesting because what CMS has said, and I completely agree with Monica, that the agency clearly recognizes that these flexibilities are going to end at some point, but they also recognize that when you're talking about healthcare services and largely brick and mortar healthcare facilities, there's a real need for that sort of off ramp. And so in addition to that 151-day grace period, they, with regard to one waiver specifically, which is the expanded Medicare telehealth services list, including those Category 3 services, they've said that those services will be covered until the end of, the end of calendar year 2023 and the end of the public health emergency. But what's interesting about that is that all of these statutory restrictions sort of work together. And we've all, over time, folks who've utilized telehealth for years, pre-pandemic, have gotten used to, well, we know the patient has to be located in this place, and we know it has to be one of these services, and we know we have to use this technology. But that extension of one of the waivers doesn't do anything for the others. And so what's important to recognize there is that even if, and there are other reasons why this may not end up being the case, but even if the expanded Medicare telehealth services list is covered through the end of calendar year 2023, if before that, 151 days after the end of the public health emergency, the waivers with regard to new types of practitioners go away, for instance, meaning that SLPs and OPs can no longer treat Medicare beneficiaries and submit claims to CMS. So it's important to note how these things fit together, because one extension in and of itself may not actually do very much if, in this example, you have services that are covered, but you don't have providers who can actually provide them. In terms of what's going on congressionally, it was sort of surprising how quickly it happened. Liz Cheney led the effort on HR 4040, which would extend all of the waivers that we have just talked about, which would have otherwise been subject to that 151-day extension through the end of calendar year 2024. And that would be a win for telehealth advocates. That would provide a period of time where we could have the type of utilization data and the claims needed to really show, hopefully once and for all, that these services can be provided without sending us off the deep end in terms of spending or resulting in rampant fraud and abuse and things of that nature. But we're not quite there yet. The House legislation passed overwhelmingly. There was one major no, and that representative pointed to concerns about fraud and abuse and wanting to make sure that there would be sufficient guardrails to ensure that the expanded access to telehealth was not going to result in that rampant fraud and abuse. The administration is supportive. The day before HR 4040 was passed, the White House issued a statement of support saying that they are on board. But we don't know if and when this will make it through the Senate. Folks seem to think, and I'm not a lobbyist or government relations professional. I have some colleagues who do that, and in speaking with them, their sense is that it is more likely than not that this should get through, but they have no idea when. And it could end up being toward the end of this year. It's something that we all need to watch very closely. So when we talk about sort of this telehealth cliff, as it were, the way I actually like to think of it is a number of potential cliffs, whether it's that 151-day cliff, whether we're talking about the end of calendar year 2023 for the expanded Medicare telehealth services, or if hopefully we get all the way until the end of calendar year 2024. And that's the point where, and I welcome others' thoughts on this. My own view is that would give us, again, the data needed to be able to hopefully get to a point where MedPAC, the Medicare Payment Advisory Commission, MACPAC, others are able to get comfortable with expanding access to telehealth services, having seen at that point that we would not have the rampant spending or fraud and abuse that folks seem concerned about. And all of this is underpinned by the fact that I think CMS, to the extent that it could do so, it's not even worth speculating, because, in the past we have seen them, the 2018 physician fee schedule final rule, for instance, carving out telecommunication technology-based services, for instance. That was, a something that was welcomed by industry because it resulted in a lot of services that are colloquially known as telehealth being categorized as something else, meaning they weren't subject to the statutory Medicare telehealth services restrictions. But CMS's hands are tied right now. So, but for an act of Congress, there's only so much that they can do.
So we're, in the interest of time, I'm going to finish that thought, but while we're doing that, if we could advance the slide, I think we want to advance it to, let's go to the next slide. We're going to transition to California. So we had a Medicare discussion. We're going to talk about Medi-Cal, and then we'll come back and talk about some of both the federal regulatory flexibilities and the state ones. But before we do so, I really want to make sure that everyone is sort of leveled up to the same place on Medicare. So what we do know absolutely is that Congress acted previously in one of the rescue packages for COVID and said, we're going to give you 151 days grace period after the COVID-19 PHE sunset to go ahead and continue doing telehealth, but on day 152, it all sunsets. And really the reason behind that conventional wisdom was to give Congress time to act again to pass legislation to do a permanent extension. Okay, so we know we get 151 days from the date of the PHE for certain. We also anticipate that Medicare, for a select number of flexibility, is able to go ahead and use discretion to extend for those specific flexibilities until the end of fiscal year 2023. And we have a piece of legislation, which if it passes the Senate, it's already passed the House, we would be guaranteed that 151 would extend all the way to the end of 2024, okay? That's Medicare. So now switching gears to Medi-Cal, I'm gonna start off by asking if Katie could first tell us sort of where we were last year in terms of the flexibilities in the Medi-Cal program, where we were heading, and where did we end up with the final budget that just came out. So that's a lot to cover, a lot of ground, but I'm opening the floor up for you to go ahead and elaborate on it.
Yeah, Sylvia, thank you so much. And if I could just take a moment, it's such a pleasure to be here. I really just appreciate all the work that Sylvia, you and the team are doing. And I feel like I have learned so much from Jeremy and Monica today. So thank you all. It's just really a pleasure. And I can't see everybody out there, but I know you're listening. And the questions that I've seen coming in are really excellent. So looking forward to this part of the conversation. Yeah, Sylvia, you're right. This has really actually been like a 2-year slog, really throughout the entire pandemic at the state legislative level. I think to your point, you hinted at this a little bit, but we really started out with, I think the administration saying, flexibilities are nice. Thanks, everyone, get your care. So glad that we can be flexible during the pandemic. But we're really going to go back to things as they were in the sort of quote before times. And I think through a huge coalition that was really led by the California Primary Care Association, so Fqhcs, along with the California Medical Association and several others, including folks here, incredible leadership and bringing together everyone's, I think all the stakeholders who were interested in telehealth really pushed the state, and I think the state, to their credit, really listened to how transformative telehealth was during the pandemic. Jeremy, I forget the word that you used, but this is just remarkable. It really is, and I know California is potentially really different as we are. Every state's different, and so I would say, our state did a complete 180 on their position with telehealth flexibilities and what will happen after the PHE sunsets. We are going to allow all those flexibilities to continue. And this is particularly pertinent, I think, to the Medi-Cal program. I think telehealth has been around, I wouldn't say in a big way, but relatively accessible in the commercial insurance market, but not in Medi-Cal, and particularly in our Fqhc community and delivery system. So this is really landmark. And the fact that we are actually here today, that the budget was signed, that the state has made a commitment to not only to pay for telehealth in all of its modalities at the same rate as inpatient care, sort of in-person care, but really has committed to, I think, including this in as a care tool going forward and allowing us to actually move into the future. So I think it's really incredible. And we really started out, I think, in a not great place. And I think today we are actually, I think on the verge of the future of care. And that includes everything from sort of audio and video telehealth, but also includes virtual, ongoing patient monitoring and other things that I think we would put more in the broader virtual care bucket and not just in the, equivalency of an in-person visit.
Can you speak a little bit to what the flexibilities going forward are going to look like? For Medi-Cal generally, but any specific call-outs with regard to Fqhcs and rural health clinics, and sort of the remarkable extensions, and then what are some of the new challenges? Or they didn't necessarily give us everything, right? There were some additional requirements added on.
Yeah, Sylvia, as you alluded to, it was a really incredible discussion. Department of Healthcare Services, they said, started out in a place of no, and then heard, I think, the coalition and said, all right, time out. We're still in the middle of the pandemic. Let's really be thoughtful about what we want this to do, because I think all of us, on the advocacy side said, wow, this is really incredible. We want to keep it. And the department said, well, we have almost 15 million people in Medi-Cal. We really do need to make sure that the care is accessible and equitable and paid for fairly. And they really, I think, brought together a wonderful group of stakeholders to really dig down into all aspects of this. What happens in the delivery system? What happens, where are the consumer advocates? Where are the health plans and all of this? They really brought all those stakeholders together and really informed, I think, the conversation in this last budget year. So I definitely want to acknowledge that. I think some of the key questions that came up, Sylvia, as you said, there was a desire to say, I think they got to yes, and that and includes parameters around these flexibilities. And those typically are around making sure that folks in the Medi-Cal program have equitable access, that we don't shift the entire Medi-Cal program to telehealth, but that there are options for in-person care when it's needed. I think specifically for Fqhc, some of the key pieces around that are payment parity. And so Fqhcs and RHCs will be getting their PPS rates for video and audio visits. That was a huge win for them. As many of you listening know, there's a lot that goes into that PPS rate. It's very complicated, and clinics can't do business without being paid fairly for the care that they're providing people. So I think that was really critical. Another piece around this is, patient privacy protection. So making sure that there's a lot of conversation around patient consent. And so there are some requirements in the bill around that, particularly in, the difference between being in person and what it means to consent to care when you're in person versus what it means to consent to care when you're just on the telephone with someone or when you're in a video visit. And then I would say, another major flexibility that we're putting parameters around is the ability to do audio only visits. I think there are a lot of questions around that. I feel like Monica and Jeremy talked a lot about this already. There's a lot of questions about what's the value of an audio only visit. And we have, I think that the team dropped in a couple key resources, but our California Healthcare Foundation during the pandemic did a lot of work on this, and they actually followed several Fqhcs and took their data, and it is so stark. Almost 95% of the telehealth appointments were audio only visits. That's huge. That's a lot of visits. Almost all, the vast majority of visits were actually audio only. And so there's some requirements as of January 1, 2024, no sooner than you have to be able to offer a video appointment. And so I would recommend you look at those requirements very, very closely, because part of the reason my organization is engaged in this telehealth conversation was because we do regional working groups across the state of California every year. And of course, we focused on the COVID-19 pandemic response for the last couple of years. And the conversation was, telehealth is so transformative, but we don't have connectivity or devices or the digital literacy to truly do video visits and beyond. We can do audio visits. We all know how to pick up the telephone and do an audio visit, but either the providers themselves or patients didn't have sort of what we call the three-legged stool of the digital divide: connectivity, appropriate devices, and actually understanding how to use them, digital literacy. So we actually we're very focused on that because we can't do telehealth, we can't do virtual care, we can't do data exchange without those three pieces. So I think there are some very, when you put a date in statute, that becomes a real deadline that people focus on. And I think in this case, it's not as simple as saying, well, you have to just offer a video visit. I think you all know that there's a lot that goes on behind that, and you can have many challenges and barriers. And so, I think a lot of these parameters that we're talking about as these flexibilities continue, it's really going to play out in the Department of Healthcare Services provider letters and all plan letters. So those regulatory actions on the back end of this are going to be really critical for you to monitor, because there are some nuances here that we are ratcheting back just a little bit. And it's not, it's not just this is in and this is out. It's, well, this is in, but. And so I think that's going to be really important for you all to pay attention to as those guidances come out over the next 6 months.
So thinking about some of the new requirements that will be implemented, three that come to mind that many may already have in place, but it's really helpful to think about, and I'm going to ask you about. These include that if you're offering audio only, you also have to ensure that you're offering both interactive video, and that's one. And then two, if you're offering telehealth, whether it's audio only and interactive video, you have to do both, for the new requirements. You also have to ensure that patients have an option for in-person. And then third, there's new requirements around how you document patient consent. And so thinking through the lens of a provider from an underserved community, what sort of opportunities or stretching is that going to require, do you think, Katie? And what are ways that we can think through addressing those?
Yeah, Sylvia, I talked a little bit about this, but you're right. All of those are going to require, I think, providers to sit and potentially get new technology to train providers in their offices and create new care protocols. It could also mean that you need to engage in quite a bit of digital literacy training for not only the providers, but also for your patients. And then I think it also could mean that you need to engage in some broadband infrastructure conversations in your area. So if you can't offer a video call because you don't have reliable broadband in your area, and we know that that's a challenge in both the rural areas, which I think everyone sort of conventional wisdom, we know that's a problem in urban areas too. LA County, I just talked with some folks in Fresno County as well. These are very urban areas who have similar connectivity problems. So you can't even get to the point where you might need new technology or to train people how to use that new technology. You have to actually even start at potentially at an infrastructure conversation. If you're interested in that and have questions, feel free to reach out to me or look at our website, itep.org. And we've got a lot of resources for health folks who are interested in engaging in that. I think those are key. I'd say on the patient consent side, I think there's also going to have to be a lot of training for providers, but also for patients and what this actually means. And I think there are a lot of nuances. There are a lot of open questions that we have not answered around the quality of telehealth. I think that this, for the first time, we've really used telehealth in a big way, and there's a lot of work going on around this. But I think it's going to be a challenge for both patients and for providers to talk about, when you consent to a telehealth visit, does that mean you're getting the same quality of care that you would get in person? And how do we create trust with our patients so that they do consent to a new type of, potentially new modality of care, or that they understand that, in this case, I actually really would like to come in person. And there's a challenge potentially on the provider side to say, okay, great, we had a nice, call, but here's the process for getting you into an in-person visit. So I think there are a lot of challenges here as well, just from a protocol perspective.
So one more California specific question, and then we'll segue back to the regulatory flexibilities, both federal and state, for the panel in toto, and then turn to our questions. But the California question is there anything left that the legislature needs to do in order to ensure in the Golden State, we can really achieve the promise of telehealth in a really equitable way that is driving improved health outcomes and bending the cost curve?
Yeah, Sylvia, I think the answer you might want is that there's a bill that's going through the state legislature this current month. It's called AB 32. And there's some fixes that to the broader bill that was passed about a month ago as part of the budget. So that's, I'd say, the near term. Yes, there are a few fixes. I don't have all the details, but it's it's changing and moving. And my understanding is that there's a movement around that. But I think further into the future, I think there are several things that we're going to need to do. And I think it really does come, I think we are going to need to make sure that we're gathering the right data. I think we are going, and there are lots of advocacy groups that are working on this, but thinking, you all from sort of the provider perspective, how are you looking at people, do people have the right devices to engage? What is your quality? Have you trained your staff the right way? I think we're going to see a lot of bills coming our way around digital literacy. I think that January 1, 2024 date, no sooner than to offer video visits and making sure that you actually have an in-person place to refer people to. I think we're going to have to monitor that. I think that's very, very soon. That's only in about a year. And I imagine that, it says no sooner than, which means it's a deadline, but it's not a deadline. I think there's going to be a lot of conversation around that, both in the legislature and, on the regulatory side. So I think there's a lot here. I think we're also going to find, and I think this was some of the discussion that stuck with me from the DHCS Telehealth Advisory Committee, is that we're actually doing this not just for now, but really for the future. And we don't know what this modality is going to look like in 5 years, in 10 years, in 20 years. And so I think a huge challenge for the delivery system is going to be getting our heads around, what does care look like now in a more virtual world? And our systems and payment structures are just not set up for that. So I think that's going to take some flexibility from all of us to actually challenge ourselves to make sure that how we evolve this modality, now that we're paying for it and we're allowing for it, I think we need to make sure that our regulatory structures allow for that innovation, so that and then we need to measure the impact that it has on quality. I think that's all going to happen in the next 5 to 10 years.
So the leveling sort of everyone again on the Medi-Cal discussion. So we talked about Medicare, federal. We've now covered Medi-Cal, California, and the news is great news in California. It really is a quite golden state for telehealth in California. Now, in addition to payment, which we heard earlier today from Dr. Resnick from the American Medical Association, their president, that payment is a big driver of, uptake and adoption, and there needs to be reliability and consistency, and we know that. But we also know that there's some other factors that can impact whether or not you can utilize and adopt telehealth modality in your practice. So I'm going to have the team, if they could go backwards on the slide deck, go back a slide. If that gets complicated, we can move forward to the next slide. So can we go backward by any chance? We move forward. Okay, there we go. I'm going to go ahead and Jeremy and Monica, I don't know which of you have decided to run point, but I'm hoping that both of you can briefly touch on the clarification that OCR issued with regard to HIPAA requirements and HIPAA approved devices and platforms and tools. But I think we definitely need to cover some of the more recent OIG guidance. So why don't we start there? Because I think that's created a lot of chatter. And I see Monica, you're ready to go if you're able to.
I was going to jump in the HIPAA, but I can start with.
Why don't we start with HIPAA? Yeah, let's Monica. I like to confuse my.
No, it's all
best practices here. So, why don't we start with HIPAA, and then Jeremy, if you're going to handle OIG, that would be great.
Yeah, because we can both do both. That's not a problem here. Just saying whoever. So I'll do HIPAA quick, because I think, as we were talking about the OIG guidance, I do think it is really important, and especially talking about the 7 elements that they identified as suspect characteristics. But so HIPAA. So real quickly, in terms of HIPAA and what is compliant during the PHE, the OCR Office for Civil Rights essentially said, look, they are going to exercise enforcement discretion, which always my mind goes to FDA, but that's okay. Enforcement discretion in relation to, the use of certain technologies to provide telemedicine services, right? So if you are using, a device and there is a HIPAA violation, they will, in essence, use enforcement discretion and waive potential penalties related to the use of non-public facing communications and modalities. And so and there's an exception for bad faith, right? So non-public facing is really a key element here. So non-public facing, think about, applications such as, Teams meetings, Skype, where you have to have actually a login. It's controlled. So non-public facing, so that only the two individuals are the ones who can actually partake in the conversation versus something like, TikTok or something like that. So if you're using a non-public facing communication and you're doing so, and the provider, of course, has, obligations to try and do this in a non-public setting. They shouldn't be sitting on the metro train, sorry, Chicago reference, to work and having, going to the hospital and having a FaceTime conversation with a patient. So, but if you are using if you're using a non-public facing means of communication and you're doing it appropriately, again, Zoom, Skype, FaceTime, and there is a Hipaa violation, again, there will be enforcement discretion by the OCR. Now, if you're acting in bad faith, then they will actually go after you for violations. So bad faith, essentially, think about further acts that are inappropriate. Are you going to take, the patient's information, then sell it, use it for other marketing purposes? Or are you using non-public, are you using public-facing means of communication? So again, TikTok, Facebook Live, Twitch, things like that would be, if you're using those, that's considered to be bad faith, and then you're not subject to this enforcement discretion. Now, in terms of planning, this is enforced during the Pqhc, of course. Planning purposes for when the Pqhc goes away, there are a number of these, service providers that are Hipaa compliant and will enter into business associate agreements. And I'm personally seeing the majority of our clients, if they're not already on one of these platforms or using one of these types of technologies with, their providers, move over. And, examples are, Skype for Business, Microsoft Teams, Zoom for Healthcare, Cisco, WebEx. Those are vendors that, even, the OCRs recognize are willing to sign business associate agreements. Now, they haven't opined on the BAs, if they're, if they meet all the requirements or not, but continued use of those technologies would be a way to ensure, Hipaa compliance. Real briefly, they recently issued a compliance guidance for the use of audio-only technologies in relation to Hipaa and what is, what they'll use for enforcement discretion. The key takeaway with that, and then I want to move to the OIG fraud alert, is the definition of what's considered to be, audio only when you're looking at the technology is very narrow. So if you are using a technology and all the audio technology doing is connecting the two people so that they can talk, it's not storing your data, it's not recording the conversation, then, that's not subject to the Hipaa, security rules at that point. But anytime with the technology that we have these days, I think there's hardly any type of smartphone that you have that doesn't potentially have the potential to record the conversations, to store the data. Those types of technologies, you're still going to want to be very conscious of the need to make sure that they're compliant with the Hipaa security rules.
Great. Okay. That was a great tour de force. So Jeremy, we're going to kick it over to you to talk about some of the recent pronouncements from OIG.
Sure, thanks. So there was a special fraud alert that was issued a few weeks ago. It was July 20th, I believe, by the Department of Health and Human Services Office of Inspector General, the OIG. And a special fraud alert in and of itself, before we talk about the substances, is significant. This is only the fourth special fraud alert that's been issued in the last decade. By comparison, folks hear about advisory opinions where the OIG opines on whether certain arrangements comply with the anti-kickback statute, and there have been more than a dozen issued so far in 2022 alone. So the fact that the special fraud alert is a tool that they use deliberately, and it's not that common. There was one in 2013 around physician-owned devices or pods, and they basically use this when there's where there's activity happening in the industry that they are getting wise to. They've seen it. They're watching what's going on, and they're suspicious. They think that there is a material risk that the federal government by way of Medicare and Medicaid, CHIP, other federal health insurance programs, is being defrauded. It's important to note, though, that in this special fraud alert, and this is consistent with how the Department of Justice originally in 2020 launched their huge telefraud takedown. And they, it was sort of with all these like big graphics and everything. And it was like, oh my, everyone was really scared. And then they sort of walked back. They said, well, we recognize that there are legitimate reasons to use telehealth. We understand that the fact that you are using a webcam does not mean that you are immediately some sort of fraudster trying to sell medically unnecessary DME to elderly folks, for instance. But what they have said is that there are these certain characteristics that they're starting to see in the market, which are, in their view, suspicious, and they're suspect. And what that means, again, is not that any one of these things means that you're going to have an investigator show up and you're suddenly going to have a subpoena that you need to answer, but it does increase the likelihood that they're at least going to sort of look under the hood, and they're going to see certain behaviors, and they're going to say, we're going to want to dig a little bit deeper. Some of the, and I'll welcome Monica to jump in as well, but of the sort of 7 characteristics that they were talking about that are suspicious, the ones that jumped out and sort of the patterns that I saw in talking with colleagues who were former prosecutors, they saw as, there's somewhat of a transition taking place, because historically, in terms of telehealth and the telehealth services that have been provided to Medicare beneficiaries, a lot of them have not been these sort of direct-to-consumer platforms that folks associate with sort of being telehealth startups. But as the industry has matured and grown, a lot of those companies, and as they've gotten successful, they've said, well, we're sort of tapped out in the direct-to-consumer play. Let's start participating in the Medicare program. And then as a result, they are then subject to federal fraud and abuse laws. When you don't participate in federal healthcare programs, big scary laws like the anti-kickback statute don't apply. And so the things that in this special fraud alert, the OIG talked about being suspicious of are, one, we talked about copay waivers here, and the flexibility that was created during the pandemic to waive copays for telehealth services, and the enforcement discretion being exercised around those decisions. This fraud alert doesn't say that doing that habitually, regularly for all of your patients is necessarily illegal, but it does say that if you are proactively attempting to advertise to Medicare beneficiaries saying that we have free devices that are going to cost you nothing and will be paid for by the Medicare program, that's the kind of thing that they think says, maybe there's something untoward going on here. They also started paying attention to clinical issues, which is sort of categorically the one that I think is really interesting and marks a change in their approach to telehealth. They specifically talked about telehealth services where there's a specific line of services that's provided. And what they're really talking about there is where you have a telehealth platform where there's a medical practice that's providing care, but it only provides, for instance, remote patient monitoring services for diabetic care and nothing else. And the concern that the OIG has is that in that fact pattern, they're worried that a clinician who's approaching a patient, and it might be an asynchronous review, not in real time, as is often the case with certain components of remote patient monitoring and for determinations as far as medical necessity and need, that the clinician wouldn't have access to the full scope of clinical tools that are available. And so it's important when you have some, in certain operational workflows, you'll have kind of a list of options, as it were, that a medical director will decide are, appropriate for the type of treatment that a particular medical practice provides. It's important to ensure that clinicians have the ability to say, in using that example of the RPM company, that they can say, well, hold on a second, based on the data that I'm seeing, RPM is not the right solution for this person. I actually think you need a referral to go see a cardiologist, and having a way to reach back out to that patient. Otherwise, again, it's not that there's anything necessarily illegal about it, but investigations aren't fun. And so folks should think carefully. And the other thing is, the way that certain prosecutors, in our view, aggressive prosecutors view a special fraud alert is that they negate the ability ability of a practitioner to have a good faith defense once something has been called out in a special fraud alert. And what that basically means is once they say in the special fraud alert that we don't think that you should be habitually and globally waiving all copays for Medicare beneficiaries, we think that's problematic. Once they've said that, that means that as a provider, you're no longer able to say, well, I didn't know, I didn't realize that that was problematic. I was acting in good faith. The way that OIG views the special fraud alert is that it's sort of like a grand decree that should put everyone on notice about these particular behaviors. And I also want to say, now that I've probably scared everyone quite a bit, I do not think that anybody in the audience at this conference is who this special fraud alert is intended to target or go after, who they're talking about. I think this is really a manifestation of what I mentioned before, that you have, with the growth of the digital health industry, a lot of these direct-to-consumer companies that were running business models that were designed to live in a non-federal payer world, meaning that the federal anti-kickback statute didn't apply, are now starting to participate and therefore getting on the radar of the OIG. This is not, if you read between the lines, this is not about brick and mortar facilities, unless it is a brick and mortar facility doing something seriously untoward.
And I will, just to kind of, add to that, because Jeremy's absolutely 100% correct in everything that he's saying. I think that this, I'd encourage everybody to read the special fraud alert, go out there. It's a short read, but it can be used as a guide of best practices, what not to do, what to avoid. Some of it, when you're looking at it, and when you have, you have a business model that truly is focused on taking care of patients and doing the right thing. Some of the stuff you're like, well, of course, why would we do this? This is wrong. And there is a focus also on patient care and clinical care, as Jeremy mentioned. Another issue that the fraud alert specifically calls out is, Jeremy mentioned one line of service, so you can't provide the full care to a patient or what they might need. Similarly, there is, a part of the fraud alert says, okay, the provider's not provided all the information they need to actually meaningfully assess the patient, to actually meaningfully assess medical necessity for the services that they're providing, where, the telemedicine platform may require that the practitioner only use audio only, say, in terms of providing the services. So they are also focusing on the major fraud things, but clinical care. So I think this fraud alert coming out actually can be very beneficial to you if you read it and really look at it and understand these are the areas that are suspect. Again, I think to most of the clients I work with, Jeremy, or probably everybody here, you'll probably read these things and they're going to be self-evident, when you're looking at it. So I would encourage everybody to read it and not be afraid of it.
Yeah, and I would also like to echo that. And there are tools, again, and checklists that CTRC can offer. And I dropped for everyone into the chat for Zoom the alert that both Monica and Jeremy have referenced. And again, these alerts really are designed with an eye towards providers and organizations that really are outliers. Remember, the federal government is like everyone else. They have a very broad scope of work they have to do with very limited resources, and they have to prioritize really those outliers. And that's what ends up happening if you're an outlier. So important to know and to use it as a guide. So with that, we're approaching the last 10-minute mark where we want to field a number of questions that came in. So this is the speed round, really related to prescribing and the DEA controlled substances, flexibilities, and state flexibilities for California. But this is really important when we start to look at mental and behavioral health services and substance use disorder prescribing. These are medications that are scheduled to or other controlled schedules. So just generally, Jeremy, perhaps starting with you, what do we see happening in that space?
Ooh, this is a big one that we left for the speed round. I will do my very best. So in terms of the federal landscape, historically, because there was in 2008, the Controlled Substances Act was amended by the Ryan Haight Act, named after an 18-year-old who tragically died overdosing on Vicodin that was prescribed by a pill mill by a doctor that he had never seen. And so Congress said, you can't prescribe schedule controlled substances without performing a prior in-person examination. They were also told that they needed to create basically a registration process, an exception for clinicians who could get trained, show that they could be trusted to do this, and then to be able to prescribe those controlled substances via telehealth without a prior in-person exam. It is August 2022, and that special registration does not exist. The DEA has been compelled to create it for years, as most in 2018 in the Sport Act by then President Trump. They were given a 1-year window. They missed it. And this is not a situation where they are in the dark. I'm sure, I don't want to speak for Monica, but I'm sure that I'm right in, saying that she and her colleagues as well. I mean, we all know who the folks at the DEA are who are supposed to have developed this rule. They hear from us often. They know that the telehealth industry views this as a huge problem for the reasons that Sylvia just mentioned. And they know that they have to do something about it. There are indications that they're going to do something about it, but at the same time, they've been saying the same thing for 14 years at this point. So our only choice is to at least plan for a world where this flexibility goes away, because unlike all of the other Medicare specific waivers that we were discussing before, which are referenced with the 151-day extension, potentially the end of 2024, none of those efforts reference the flexibilities on the controlled substances prescribing issue at all, and they're not expected to at this point. And so, again, we expect that there will be some action, but absent that, we need to assume that there will, again, under federal law, be a requirement that there's, absent certain exceptions, which are more geared toward brick and mortar facilities than telehealth platforms, that a prior in-person exam is needed before prescribing those controlled substances, unless there's an exception for covering practitioners. There are certain practice of telemedicine exceptions, but that's really if the patient and or the provider are located in a DEA registered brick and mortar facility. Fortunately, California is not one of once this federal floor was removed during the pandemic for the first time, everyone suddenly said, oh my goodness, we have to look at state law now, because there are state laws on these issues. And in the past, it was that we had this federal floor. Some and states fall into different categories. California is a state that does not expressly prohibit prescribing controlled substances without a prior in-person examination. Now, that is not to say that folks should go rogue and start slinging amphetamines all over the place. Like, this is still an area where we're talking about drugs that are controlled because they have the potential to be dangerous. But in terms of what the landscape looks like moving forward, fortunately, we can say California is not one of those states where some states incorporate the federal law into it. And so as a result, the fact that the federal law is waived actually doesn't do those states any good, because then state law says you need to abide by the requirements of the Controlled Substances Act and the Ryan Haight Act. But it could be worse. California is not one of those states, but it's an area to watch very closely, because it's entirely on the DEA, separate and apart from Congress, from the Medicare program to act in this area.
So we have a 5-minute warning. We have 3. Thank you so much, Jeremy. I think you did a great job. That was a fantastic overview. I think, in fact, one of the best I've ever heard. So with that, there are sort of 3 categories of questions that have come in. The first has to do with, and this really is relating back to the Medicare direct supervision question. And we had a question about basically what are the parameters around the direct supervision requirement? Does it apply to various different types of practitioners differently? For instance, MAs, preceptors, mental health supervisors for MSW. What does the current flexibility look like, and what does it look like we're going back to? Monica, you're on mute.
Sorry, I was having problems. I had that spinning blue circle when I was trying to unmute here, so sorry about that. No, so those are good questions. As mentioned, the direct supervision requirement pre-COVID applies for when you are going to be submitting for reimbursement, services that are ancillary to a physician, to physician service, anything that's, reimbursable like that. So if you're having, if you have a medical assistant and you're going to be, submitting their services if they're ancillary to the physician services for reimbursement. Right now, the supervision requirement means that the physician who's supervising can be remote and can use, audio visual supervision for those services. Again, when the waivers go away, you're going to go back to the traditional direct supervision requirements, which will mean the physician, the supervising practitioner will actually need to be physically in the same building as, the provider that is actually providing those services.
Okay, and then we're going to finish up with one more question, and that is, do Fqhc providers need to be on site doing telehealth visits, or can the provider work from home? So, do I have any takers?
Sylvia, is the answer, it depends.
Yeah.
It really depends what state you're in and what program you're billing to, right?
Right. That's exactly right. It depends on whether you're talking about Medicaid, and that's highly variable based on the state. It also varies whether you're talking about Medicare. And so this is one of those situations where the complexity does really require sitting down with CTRC, other resources, to go through who your payers are, what their requirements are, to really map out a plan. And I cannot thank our panelists enough for the breadth of knowledge, experience, dedication to advancing sound telehealth practices, aiding communities, providers, and their patients to do this good work. And with that, we're going to end almost exactly on time, and I look forward to continuing this dialogue with you all again in the future and collaborating with you to advance these goals. So with that, we'd like to thank you.